So we're starting today with arguably the most important person to patients inside of HHS, our enforcer, Leon Rodriguez. And so since he's come to the Office of Civil Rights, we've suddenly seen a tremendous emphasis on holding institutions, companies, and others accountable for what they're doing with patient data and whether they're protecting it enough. And so he's going to talk today. Just to tell you a little bit about him, I think the reason he's so tough and so wonderful is he's a DA. He comes from prosecuting and defending the public, and so he's very, very interested in the nexus of health and civil rights. And so, Leon, thank you for coming. Please come on up. Please welcome him. Thank you.
Okay. First, the ground rules. I'm going to take off my jacket, and that's my way of telling you that we are going to use parliamentary procedure here this morning. Those of you who have observed the British Parliament know that heckling is permitted, which means that you should feel free to, at any time, from any place, ask questions, make comments, and if you feel the desire or need to go ahead and actually just heckle. So I should tell you how cool it is to be here in the Georgetown Law Center, Georgetown University Law Center, because the last time I was here was something like April or May of 1985. And I had just been waitlisted at the Georgetown University Law Center. And I came to visit the dean in order to see if I could talk my way off of the wait list and into admission. And the dean looked down at my transcript, and I had a fairly unillustrious undergraduate career, and he said, "Wow, it's a miracle you actually got on the wait list. I don't think you're going to be getting off of that." So it's great to now be lecturing at Georgetown University Law Center. So I think the main, one of the important questions I'd like to ask and at least start answering this morning is, why is health information privacy in the Office for Civil Rights? How was that a match? Why would that decision have been made back in the late 90s after the HIPAA statute was passed? And I think it makes it an opportune moment to talk about our origins as an agency. We were founded in 1967. We were one of many offices for civil rights that were created throughout the federal government. And at the beginning, the primary authority that we enforced, and is one of the ones that we continue to enforce, is Title VI of the Civil Rights Act of 1964. And back then we were health, education, and welfare, and so we enforced that with respect to desegregation in the schools, particularly in the South, but really throughout the United States. And one of the earliest holders of my position was actually Leon Panetta, who in the early part of the Nixon administration was the director of the Health, Education, and Welfare Office for Civil Rights. And then Director Panetta, later Secretary Panetta, went ahead to do his job. And he began to enforce those desegregation orders that had been issued by so many courts throughout the United States to require desegregation of schools in the South. And that was a little bit of a problem because those of you who are either students of history or those very small number of you who might be able to remember that far back, the Nixon administration had a political strategy called the Southern Strategy. And the main element of the Southern strategy was to appease the segregationist political structure in the South by moving as slowly as possible on desegregation. And so Secretary Panetta's tenure in my job lasted 14 months before he was actually fired. And it means that we have a heritage in the federal government of always being the advocates for those who are on the outside, those who are not necessarily at the levers of power. Now, what does that mean? for health privacy. And I point out that if you are a person who is HIV positive, you need to be able to control when, how, and where your family, friends, and community find out about your health status. If you are a person with mental illness, you may not confide in your provider. You may not go to your provider at all unless you are confident that what you say will be maintained in confidence. If you are a victim of domestic violence, you very often can ill afford for your abuser to know that you went to a doctor at all, that you disclosed the source of your injuries. And so it's all about protecting those victims as well. And this was really brought home to me by a few recent appearances that I've had. Probably the most poignant of them was an event that we had at the Whitman Walker Clinic just about 2 weeks ago. I actually brought my children to this event, and it was to roll out this advertising campaign, Information is Powerful Medicine. And it was a campaign that we've done in partnership with the Centers for Disease Control, with Whitman Walker, with AIDS.gov, and it is specifically directed at black gay men to talk about their rights to have control over their health information, both to be able to depend on the privacy and security of that information, but also to be able to have access to that information so that they really can be real participants in their own care. And so one of the speakers at that conference was a young man who really brought it all together for me, really brought every single strand of what we do in the Office for Civil Rights together in one 3-minute speech, because he was a member of a minority with a disability, and he had the following story to tell. He said, I lived in a small town in South Carolina when I was diagnosed. And nobody kept my information private. And so my entire community found out that I was gay, which they didn't know, and they found out that I was HIV positive, and it meant that I was ostracized in my community. He said, but then I came to Whitman Walker, which is a wonderful health facility. They've been treating me, they have been inviting me, allowing me, and empowering me to participate in my own health care. And in order to help me live with HIV, but still have a healthy, productive life. So it was all there together: privacy, access to information, protecting people with disabilities, protecting traditionally vulnerable groups, all in one appearance. So when we ask whether privacy is civil rights, I think no story illustrates that more than that appearance. About a month before that, I was invited to speak at the National Minority Quality Forum. And I was expecting to be asked to speak about health disparities. Normally that's what they ask us to talk about at the National Minority, at these sorts of gatherings. And so to my surprise, what they wanted me to talk about was actually about privacy security, and in particular in the context of electronic health information. And they had this to say. They said, many members of different minority groups are now going to be entering really the medical system for the first time in their lives. And they're going to be they're going to be using electronic health information exchange. They're going to be going to doctors more regularly because of the Affordable Care Act and because of the advent of electronic health records. We think a lot of those folks are going to be worried about whether they can trust in the privacy of their information. And so we need to really make sure that those communities are confident that their information is in fact safe, private, and secure. And then finally, we started a YouTube educational campaign. We have these wonderful sort of 1 and 2 minute videos that describe different aspects of the privacy and security rules. And one of them is titled in English, Your Information, Your Rights. And then we took that video and we translated identically into Spanish, Su información, sus derechos. I will tell you that we have had as many hits on the Spanish site as on the English site. So think about what that means. That means that in Spanish-speaking communities in the United States, there is an interest in health privacy, and even I don't know why it is. And that's an interesting question. That's an interesting, and Deborah just said she knows. Actually, I'd be curious.
Well, I think it has to do with the nature of trusting someone in any relationship. There are only a few people that you trust, or I trust, or anyone trusts to talk about really sensitive matters. It's not the Hippocratic Oath. And if you have something personal to tell a doctor about, you want that kind of trust that you give to very few people in your life. That's what I think.
So that, I mean, that makes a whole lot of sense to me. And what it above all illustrates is, if we want to give vulnerable communities access to care, then we do need to be safeguarding their privacy as much as any other civil rights issues that we're safeguarding in our office. Yeah.
Well, I'm a Latino, but I was also talking to a doctor from Mexico, and I think she and I would agree that culturally, Latinos are just not as open with their, Latinos mostly are just not.
I can hear it. I don't know.
Working now? There it is. Okay. They're just culturally, they're just not as open with their information as other populations. And that's what I found out.
Yeah, I mean, I assume that with all things, there's variations on that theme. I certainly think something that I've seen in the law enforcement context, not just with Latinos, but with immigrant groups generally, is a distrust of any kind of authority. In part because of experiences in their home countries, and in part because of things that actually happen here in the U.S. As well. So I mean, I think there might be a kernel of reality in that. But it certainly, I certainly view it that from our perspective, it really means that we need to be reaching these community with privacy and security messages. So how are we doing it? So we're giving you the examples of the educational tools that we are using. We have YouTube videos, we have Medscape videos, and one of the wonderful things about these Medscape videos is that they're actually directed not just at large institutional providers, but also at smaller providers. And our mobile device security toolkit, especially as mobile devices come to be used more and more by physicians, and as patients want them to use them more and more, there's a need to make sure that there's an understanding about what the security expectations are for those devices. But the other way in which we are making sure that information is private and secure is through our enforcement work. And there are really three legs to the stool of our enforcement and compliance work. One is the traditional enforcement work, bringing cases against specific providers. Two is our breach notification, which is giving us a way to identify vulnerabilities throughout the healthcare system and develop approaches to plug up those vulnerabilities. And the other emerging leg to that stool is our audit work, which was piloted back last year, and which I'll talk about for a few moments, and I think you'll hear a little bit more about it during the conference. So let me first talk about the enforcement work. Until around 2008, 2009, our primary model for enforcement is what in law enforcement we call a reactive model. We would receive a complaint, ordinarily from a patient. We would, if we found that that complaint actually presented a possible violation, we would investigate that complaint. We would issue a letter of findings, and the primary remedial step that we would take in those years was to issue what we would call a corrective action letter, which is basically to communicate a set of expectations to the providers, work with the provider to correct what the deficiencies were that resulted in those violations. And that continues, by the way, to be our primary model of enforcement. Most of the cases we do are done in that manner. But I think we learned before too long that that was not enough, that we needed to think about the things that we were doing differently. So a couple of things happened. Until the HITECH Act was passed, our maximum per year fine was $25,000 per year per regulatory section violated. And we almost never used that authority. In fact, the regulations made it kind of difficult for us to use it. And also, we weren't using that authority. And so HITECH really changed that because it took that $25,000 and it bumped it up to $1.5 million per code section violated per year. And it also really lowered the bar of when we could use that fining authority. So now, even though we don't ordinarily use it this way, even if the only finding we make is a finding of strict liability, in other words, that there's no possible way that the entity could have known that they were committing this violation, even in that circumstance, we could, in fact, fine up to $1.5 million. We don't ordinarily do that. But we have started using those fairly aggressively and being very vocal about the fact that we are using them. Because I came to believe after many years in law enforcement, and I've been in law enforcement in wearing many different hats. I was a street prosecutor, I was a civil rights prosecutor, I was a healthcare fraud prosecutor, and so I've seen how enforcement works in a lot of different environments, and I do believe fundamentally that enforcement breeds compliance, and enforcement fosters compliance. If for no other reason than if you go, and I spend a lot of time these days going to these kinds of conferences where you have lawyers talking, you have CIOs talking, you have compliance officers talking, they talk about risk. They talk about if you do this or you do that, there is a risk that OCR is going to come to you, they are going to investigate, they're going to cost you a lot of lawyers' fees, and then in the end they may impose a penalty on you. And that changes the calculus. That changes business decision making when that happens. Now, how do we choose the kinds of cases where we use these authorities? The one thing that I think we should not be doing is playing a game of gotcha with providers. So that a single bad decision on a single day becomes a way to provide an otherwise well-meaning, well-intentioned provider in the jackpot. The consequence of doing it that way would be, in fact, very often and in fact, without even doing it, I think some of this environment exists, would actually inhibit providers from doing some things that we actually really do want them doing on behalf of patients. But when we have systemic and repeated failures to comply with various rules, several rules, in the privacy and security rules that correspond to a real risk of harmful breach of that information to the patient, then it is in those cases where we really do need to use our enforcement powers and use them fairly forcefully, use them in a way that sends a message. Or in a case where you do have a single disclosure and the reasons underlying that disclosure are fairly craven, then in those cases as well, those are cases where if it's not a criminal case, we in fact should be using our fining authorities. And so here you have a series of examples of the amounts that we're talking about, some of the kinds of entities. Now there's some variety among the underlying facts of these cases, and I certainly would invite you to visit our website, which would give you a lot of details to what these cases were about, but there are some common themes. In many of these cases, one of the fundamental failures of the entities was to conduct a risk analysis, was to examine thoroughly their business operations, their business processes, their business setup, to find out where protected health information was stored, what the vulnerability of that information was, and what steps needed to be taken in order to effectively secure that information. Those same findings were mirrored in the audit process that I'm going to talk about in a few moments. But there's also another significant case I'd like to point you to, which is the Signet Healthcare case that is about in the middle of the chart. You'll notice that's the largest penalty we ever imposed, $4.3 million, although we've only collected about 30 of it, actually. That was a case where the entity failed completely to disclose health records to their patients, and then made it worse by failing to cooperate with our investigation. And so that is another kind of scenario that could end up as a penalty scenario. Now, we scale these monetary settlements, we scale these penalties to a variety of factors. How many records were vulnerable? How many records were compromised? How big is the entity? How serious were the violations we're talking about? So that also accounts for some of the variation among the entities. And one thing that I'll emphasize is that at this point we are not looking to enforce against any particular kind of entity. And so if you read trade media, when we did the Phoenix cardiac surgery, they said, oh my God, this must mean that they're going after physician practices. But it wasn't the case. That just happened to be the case at that time that was in the queue. That could change. We could, if we identify industry sectors where there are particular problems, then we may in fact concentrate our energies on particular industry sectors. But at this point, in what is still, to my mind, still the relative infancy of our enforcement program, I don't think we're going to be doing that. So I talked mentioned the breach, and I want to give you a little bit of time for questions. The breach notification process, we have received approximately 600 large breach notifications, closing in on 80,000 small breach notifications. As I indicated, the primary purpose of the breach exercise is to identify problems and then have a process for correcting them. Some of these cases do result in enforcement, but it's a relatively small number. But one of the things that I emphasize when we talk about our breach experience, and this has really been true since day one, is that a relatively small portion of the breaches that we see are actually hacking breaches. Many of the breaches actually are physical security issues, things that either get up and walk away or are helped to walk away by somebody. So we're talking about theft and loss of laptops, Blackberries, iPhones, and paper records that get stolen. And one of the things that experience emphasizes is the importance in any kind of healthcare provider of having effective policies and practices to protect that information, and of then enforcing and living by those policies. Because very often the failures that underlie those kinds of breaches are associated with failures to have appropriate disciplinary and performance policies for employees with regard to the protection of health information, training for those employees, as other examples. Audit for me, and that's the third leg of the stool, is really the most exciting new frontier of what we're doing, and it's for this basic reason. Patients can only see a little pinhole of what's actually happening to their health information, especially now in the electronic environment, where very often their health information may not even be in the doctor's suite. So if we rely only on complaints from patients to go searching for violations, we will have failed. We will not have effectively identified where all the vulnerabilities are. So the audit process, especially if we do it with a thoughtful menu of points of audit, really provides us a way to look at the entire process of protecting health information, look at the places where we most worry about vulnerability of protected health information, and examine a random selection of providers to see if they're in compliance, and therefore another way of sending a message to the entire industry that we're on the watch for these issues. Our pilot taught us some interesting things. The risk analysis issues that we see in the enforcement work, same exact issues in the audit process. But one of the most interesting and not necessarily expected findings was this one. As you know, or as many of you know, there is an encryption, what we call an addressable encryption requirement. in the security rule, which means you either encrypt or you explain why you're not encrypting and do something that is about as good as you can get. Mostly the audit found two categories. Entities that encrypted, so actually went to the top of the rule, or entities that did nothing at all. In other words, didn't encrypt and couldn't explain why they didn't encrypt and couldn't explain what they were doing instead. Probably most of them were using password protection without realizing it, but they couldn't explain what they were doing as an alternative. And it begs some interesting questions. Is the issue, in fact, that if you go through the thought process as to what is the most effective, reliable, safest, the thing that will most likely keep OCR off your back, if you go through that thought process, you will decide to encrypt, or is it in fact that you haven't thought about it at all, and you haven't really gone through that thought process at all? I think it's probably a little bit of both. But I think that's one of the interesting things that we are going to be learning about as we go down the line. Lots more to talk about. I think the main thing I want you to know is we are in fact open for business. We are eager to hear what you have to say. I was telling Deborah this morning, who, by the way, I think has been a tremendous leader in this field, is one of those great examples of how you take an idea, you herd the cats, you put some good ideas out there, and you actually have a movement that eventually follows it. But I think the industry finds me really easily. They invite me to lots of conferences. They come in to visit me all the time. Consumers less so. And so the dialogue that I have with those who speak for consumers is particularly important and a lot harder for me to find. So I really welcome any thoughts that any of you want to bring to us. Thank you.
We're running a teeny bit late, but it might be nice to have 2 or 3 questions.
Hi.
Yeah, Adrian.
One of the ways to engage consumers and an issue maybe for audit and enforcement that you mentioned is accounting for disclosures. Where would that stand in respect to, again, either as part of the enforcement issue or the engagement of consumer issue?
Right. So, I mean, I think part of that question relates to the accounting for disclosures proposed rule, which, as you know, is we're still in the process of concluding our review of the comments to that rule. So right now I'm not in a position actually to say a whole lot on that issue.
But it's coming.
But it's coming.
Of course.
Anyway, I'm Andy Orm. I'm going to be writing a lot for app developers. We all know apps are a big part of the future of healthcare. They can have security flaws, and software is notoriously impervious to legal responsibility. I wonder, you could comment on that, but I also wonder if we should be warning the end users in medical institutions to examine the apps they're using and protect themselves.
I mean, I think that's, when we talk about risk analysis, that would seem to be an important part of risk analysis, is to make sure that the tools that you are using have the security that you think it does. And that it has the security that would have you ultimately in compliance with our rules. Now, I emphasize that our rules do not prescribe a specific security approach or a specific kind of security, but they do require an actual process to evaluate whether, in fact, the things you are using are providing you an adequate level of security. Sir.
Nick Terry, Indiana University School of Law. If you ask a patient privacy advocate like Deb about sort of the #1 issue at the moment, it's patient control of their information. If you ask a health policy wonk, it will be data interoperability. As you go in as a prosecutor, and I add my plaudits, by the way, for what you've done, do you see a tension there as providers react to OCR and enforcement by just wanting to lock everything down? And do you attempt to resolve that? Does that come into your analysis when it comes to enforcement?
Yeah, it's an interesting question. I think there is a tension. I'm actually a person who thinks that tension is sometimes useful because tension helps you sometimes balance priorities, balance sort of competing issues. To me, the patient always needs to be the fulcrum of the discussion. And I think a lot of these questions ultimately can be resolved thoughtfully and correctly if both the interest and the dignity and autonomy of the patient are the fulcrum of the discussion. Then I think you'll end up in the right place on these issues.
Thank you.
Let's do 1, 2 real quickly,
Okay.
because we are a little late, and I'm sorry, I think I caused a little of the delay, but
Melinda Beck from the Wall Street Journal. I'm curious to know what your message to the Black gay men and other people trying to understand this rule is about how much control they will have, because even though you are enforcing HIPAA very aggressively, HIPAA does allow so much sharing of information behind the scenes with other providers. And what if you hear from these gentlemen that they don't want this information shared? How much control will they actually have?
Well, they do have a tremendous amount of control. I mean, I think that the primary message of the campaign is actually that they should get access to their records.
Again, that access doesn't equal control.
No, but that's right, and so that's certainly another issue that they should be aware of, is that they can control who gets their information and for what purpose.
But they can't in many cases, can they?
No, I think they can. I mean, I think they are able to tell their providers, I want you using my information in this way. I don't want you using my information in that other way. I want you giving this information here. I don't want you giving it in another place.
But the providers can say no. They can say no. You can request restrictions on disclosures, but they can say no.
That's absolutely right.
That's the problem.
Well, not, I mean, perhaps within the provider's entity, but in terms of disclosing it outside, if it's not a permitted reason under the privacy and security rules, they can't disclose it if the patient tells them not to.
It seems to me an awful lot of sharing is permitted under that rule.
No, I mean, you know, what I will say is the way the rules are set up, it does require a certain amount of volition on the part of the patient to make sure that the provider does not disclose their information outside of the provider's institution in a way that the patient does not want. And so it's not always the case necessarily that we're expecting the provider to directly ask the patient, you know, will you allow me to disclose the information in this way? We certainly recognize certain kinds of implied consent based on the behavior of the patient, explaining to the patient what you're going to do with the information. You know, that's probably something we could talk about, whether that's the most effective way to do it. But that's certainly the existing architecture of the rule is perhaps does require more effort on the part of the patient to ensure that their information is not disclosed in a way that they might not want it to.
And is the data segmentation in place that would allow that to happen, even if all sides agreed that it should, when all these records are being shared so widely?
I think that's an issue that may vary from place to place and issue to issue. I mean, it's hard to answer that question just as a sort of global matter.
Thank you. Thank you. Okay, if you're really fast, because I'm so
I'll be
sorry.
okay.
And I'm going to answer it yes or no, no matter what it is.
Okay, I think it is a yes or no, so.
Thank you.
My understanding is for HIPAA, I'm not sure about high tech, but for HIPAA there is no government agency or piece that certifies ACOs or hospitals or practices, whatever, in their compliance. And so that being the case, the whole risk analysis you discussed seems to be all monetary based, nothing to do with human dignity. And it just seems that we kind of need a grading system like the FDA might have or whatever, and the ability for these people these organizations to comply and get a grade on it so that the consumer actually knows where not to go.
Yeah, I'm not sure whether my answer to that question is yes or no. I will say that you are presenting what I think is a really important dialogue that needs to happen. Is this notion of certification of compliance? I think that's something that sits out ahead of us.
Well, I don't know what you all think, but what I think, and I hope you'll join me in this, is we would really like to have you back next year and have a fuller dialogue, because
Okay.
we hear
Okay.
we hear what you're saying and your defense of patients, and we know that's what you want to do. And so
Okay.
this was so excellent.
It's a deal.
Okay, it's
Yes.
a deal. Okay.
I'll answer that question.
I'm gonna
Yes. How
tell
about that?
Juliet you're coming next year early. Okay, and we'll give you more time. This is superb. Please, let's thank Leon. I'm just so sorry we're on such a tight schedule.